We are live. Please unmute and start.
Hello, everyone. Warm welcome to all of you. We had a wonderful session yesterday, and I'm sure we've learned a lot from the day one of the controversies in thyroid and in metabolic disorders. Today, we have another plethora of speakers, and you can call them a galaxy also of speakers with eminent personalities like Dr. Usha Madam and Dr. Shaila Bhattacharya Madam, guiding us through their wisdom, chairing these two sessions on metabolic bone disease and pediatric endocrinology. So the first session is going to be on controversies in metabolic bone disease. I'm sure that it's difficult to cover all the controversies in 1 hour, but I think I've left the responsibility to Usha Madam to take over these into that particular session. To introduce Dr. Usha Madam, I think it's just a formality. We all know her as a eminent personality. She's one of the topmost and most, you can say, the endocrinologist with a lot of compassion, lot of empathy, and lot of educational awareness on women health is what her forte is. She's a graduate of Madras Medical College. She's an American board certified in internal medicine and endocrinology, diabetes, and metabolism. She's the head of Department of Endocrinology and Metabolism at the Voluntary Health Services at Chennai. She's a president of Indian Society of Bone and Mineral Research, and she's founder of the Divas. Divas has been doing an excellent job in educating women in diabetes and getting awareness on this forum. In fact, now she just told me that she started with an e-booklet on creating this awareness globally. And she has special interest in GDM, women health, osteoporosis, preconception care, and medical ethics. And who else but Dr. Usha could guide us through this controversial topic of metabolic bone disease. So over to you, ma'am, and hope to listen to you in the next hour.
Thank you so much, Vaishali, and such an honor to be part of this discussion and this group and this conversation, which is really, really important. So can I have and it's my pleasure to introduce Dr. Beena Bansal and Dr. Tejal Lathia, who will have a duologue, and then we can have a discussion. So Dr. Tejal Lathia, present designation is at the is an endocrinologist at Apollo and Fortis Hospital, Navi, Mumbai, co-author of Language Matters for People Living with Type 2 Diabetes in India, first prize National Conference paper on autoimmune thyroid disease and autoimmune gastritis, 10 specific publications in 2020 and 2021, research intents digital therapeutics, PCOS, diabetes communication, menopause, and women's health. Her current research is she's collaborating with University of Birmingham in project called PCOS Seva, and will be presented at the UK Endocrinology Society meeting 2021. And next is Beena Bansal, whom I've also known for a very long time. Beena is a MD Medicine, DM Endocrinology, based in Delhi, founder and director of Door to Care Endocrine and Diabetes Clinic in Gurgaon, and president of Saksham, a type 1 diabetes welfare society, former director of endocrinology, Medanta, the Medicity. Again, someone with a lot of interest and expertise in bone health. So I think this will be a great discussion. So can we go forward with the duologue, please?
Good evening, ma'am.
Yeah, once you both are done with the discussion, we can jump in and have some comments on that.
Yeah. Actually, you can join in from the very beginning. I know that this is a topic of interest to you as well. Tejal, I can't see her.
I'm here.
Hi, Tejal. Yeah, so
I'll start.
You'll start the discussion. So
yeah, please go ahead. Finish.
I thought we'll just set the format that we are going to just have me and Tejal asking questions to each other, creating controversies for each other, and then maybe we can invite the chair people also to give their point of view on that, because I am sure in vitamin D there is no controversy yet fully resolved. So there will be points and counterpoints on each of the topics. Yeah, go ahead, Tejal, please.
So, as Dr. Beena said, we'll ask each other questions. But if anybody has, wants to add to the answer, then please just unmute yourself and step in. So, I want to ask what sounds like a very normal question, but which is difficult to answer. Is what is normal vitamin D? Is there any one number where you say, okay, now this person has normal vitamin D?
Yeah, this is an important question because we understand that many lab reports show a normal vitamin D, and that creates so much of a panic in people who come with the reports. And we understand that there is a problem with anywhere definition of normal for many different hormonal values, vitamin D especially being the case. So there are different definitions by different society. And that depends on what is the impact of different levels of vitamin D on our health. So at one point, there is, I think, a unanimous agreement that a value of below 10 or 12 nanogram per ml is associated with rapidly progressive osteomalacia and rickets. So there is a level beyond which, below which you have manifestations, clinical manifestations of bone disease. And therefore, less than 10 nanogram per ml or less than 12 nanogram per ml has been defined as severe vitamin D deficiency. So we'll take for whole number kind of thing, less than 10 nanogram per ml is severe vitamin D deficiency. And that is a level which we all agree upon mostly, that needs treatment immediately. However, beyond that, for long-term impact on bone health, less than 20 nanogram per ml is also considered a cutoff, because a value below 20 nanogram per ml over a long period of time may result in increased PTH and osteoporosis in future. Therefore, in most bodies define vitamin D deficiency as less than 20 nanogram per ml. Now we understand that vitamin D is not just a bone hormone. It's like a multitasking hormone now with multiple roles. And those roles go beyond bone to heart. For example, there is an association of vitamin D deficiency with heart, cardiovascular disease, with cancers, with a lot of complications in pregnancy, which Dr. Ushan, we had discussed, and we'll cover that maybe in this. And also dementia, autism, cancers, type 2 diabetes, type 1 diabetes, and therefore maybe a level less than 30 nanogram per ml. So we may want to push the level beyond 30 nanogram per ml for all these reasons, especially maybe in high risk people. It may even be higher up to 40. Now, the controversy arises from the fact that although there are associations of level less than 30 or less than 40 with many of these diseases, interventions have not resulted in improvement. So till the time we have data which shows some long-term benefits by pushing the levels beyond 30 or beyond 40, maybe a less than 30 nanogram per ml as defined by most endocrine society guidelines and Indian guidelines being insufficient is a fairly right description. So what do you say, Dr. Tejal and Dr. Usha, please?
So I think I completely agree with you about the less than 10, and I think pediatricians typically talk about 12, and I agree with you. And then this 20 is definitely, many consider as above 20 is okay, but above 30 is ideal. So, but really this does not apply to women of reproductive age, because if they walk into a pregnancy with these levels, clearly they end up with, and then one of the other good properties of vitamin D I want to add is immunomodulatory properties as well, especially the 125 dihydroxy vitamin D3. So we need to, that, which is why even in early pregnancy, even though we know that we really need the vitamin D for in the third trimester when the bones are growing, but why does in a normal pregnancy 125 so high even in the first trimester is because nature has made it go up from an immunomodulatory perspective. So I'm just saying that we should push women of reproductive age, the ones who are as a part of preconception care, to have a really good vitamin D level, And I'm not talking about, I'm sure you'll discuss that. That's why I did not go into the questions in my head about controversy, because I did not want to preempt the questions you have in mind. But then, those things come into like when you test and when you treat. So as a public health thing, we should promote, optimizing vitamin D levels in everyone, especially in women of reproductive age, because again, with vitamin D having this fetal vitamin D deficiency being involved in fetal programming, and then also causing diseases later in life. So the only caveat I would add is that in these women, it should be higher. What should be normal for them?
Can I ask a controversial question? So we all know that studies in India show that we have vitamin D deficiency up to even 90-95% of our population. Even in rural areas, it's very high. Do we have any data from India where actually we've looked at what is normal for our population? At what point does the PTH take off? At what point does the bone health get? Because I remember I was at a conference, the ISPE at one time in Bombay, and one of the Australian scientists came up to me and said, you know what, you're presenting all this data that vitamin D deficiency is ubiquitous in your population, but have you even really looked at what is normal for your population? So it is a controversial opinion, but I would really like to know what thoughts you have on it.
Okay, so you're asking me this. I'm sure. So there are trials of, I think, so there are a lot of trials in pregnancy, I know, where vitamin D levels and outcomes in babies, in Indian trials. I think data which shows that low levels of vitamin D has poor impact on kids' bone health. I have to still go through those studies. I'm not sure about PTH association with where does PTH start taking off, if those kind of studies are there. I would ask Dr. Usha if that is there. There are studies to show that low vitamin D is associated with osteoporosis maybe, but a longitudinal kind of a study, I think it's really difficult to kind of plan and implement. But
yes, it's a controversial question. There is no right answer.
Well, I don't think there is a. So will come.
Normative data, when 90% to 95% of the population have a certain level, is very difficult.
Right.
So, so that's the first thing. The second thing is, this question of at what point does the PTH, take off? That's again something we have a very unique, Indian, challenge there as well. We just don't seem to have for that level of vitamin D, we don't see the PTH levels that's usually seen. There's some data about magnesium levels playing a part in that as well. So definitely, so I think what we need to do is, one is when you look at, maybe we can discuss that later, like when should we look at a vitamin D level, and therefore, when does this controversy actually plague us?
Yeah, so I think we'll bank those questions, and 3 more are there in the chat box, Tejal, but
Sure.
let me go through the next series of questions, initial discussion,
Yeah.
because I think that will ultimately lead to those
Sure.
answers which are there in the. So, we thought we'll ask the questions step by step, like how do we supplement? What is the optimal supplementation dose? And again, what is that based on? And then we can come to the association studies of vitamin D, and why don't the intervention studies show improvement? Because that is also there in the chat box. That's part of your answer also. So, how do you think we can optimally supplement vitamin D? And maybe you can also take along with that, why is there controversy about what is the optimal dose, and why have the intervention studies been so controversial? Maybe we can discuss that. So what is the optimal supplementation dose or supplementation dose of vitamin D?
Yeah. So what is recommended, at least by the ICMR, is just 400 IU per day, so which is a very, very small supplementation dose. But if you look at supplementation doses across the world, then in people who are low risk, then maybe about 600 to 1000 IU per day is what would be usually recommended. And in patients who are more than 50, risk of osteoporosis, or have certain high risk conditions for vitamin D deficiency, then even up to about 2000 IU is recommended. However, if you take that step further, because when you listen to those numbers like 600 and 800, you know that it's going to be woefully inadequate to actually get people to get their vitamin D levels out. So even up to 4000 IU per day, but that's the upper limit at where all the societies stop. But if you look at the toxicity studies, and even up to even 10,000 IU per day, there isn't significant toxicity unless it's given for a very prolonged period of time. So anything between maybe about 1000 IU on an average for somebody who's an average person, up to 2000 to somebody who's high risk, and then higher doses for special conditions, for pregnancy or whatever. Also, the ideal supplementation, the way you supplement, of course, this is now again hugely controversial. And when I was at Nair, we had just, when I was in training in medical college, we just come out of the IM 1 weekly 3 doses thing, and we'd finally come down to about 60,000 started hitting the market at that time. And what we were taught is the IM is bad, and the oral 60,000 is the right way to supplement vitamin D deficiency. However, if you look at the data, and there are several studies where they've actually compared a single intramuscular injection or a single large oral dose versus daily dosing of 1,000, 2,000 IU per day or 60,000 weekly. And there is some data to suggest that the single dose of approximately 3 lakhs causes much longer lasting vitamin D levels as compared to the oral daily dose as well. Again, yes, this is controversial. That's why I'm specifically bringing this up, because of course there's conflicting data as well, that when you give one single large dose, then you push up the vitamin D levels really high. There's hypercalciuria, there can be hypercalcemia, especially with the repeated doses. And how to go about it? Of course, 60,000 weekly for about 8 weeks, and then supplementation, 2,000 IU daily, or a single dose maybe once in 3 to 6 months are the ways that you could supplement. Dr. Preeti, I'm not commenting about the children because these doses sound high as compared to what I advise in children. Right. So Dr. Preeti, pediatrics, I won't comment on. And Dr. Bina, you want to add something? Dr. Usha, you want to add something?
Quickly, there was a study in kids we did at Medanta itself, and in them, in a very small dose increased vitamin D levels much higher. Right. Vis-a-vis adults, where we saw that 1,000 or 2,000 units per day also did not cause as much increase. But for kids, the recommended doses are 400 to 600 IU, and at different age groups. I will check that out. But
I think ma'am is talking about nutritional rickets. She's talking about nutritional rickets. So she's talking about a treatment dose, and what you're talking about is a supplementation dose.
Yeah, even for kids, the supplementation doses are also much less, and there is that whole table. I think we'll invite Dr. Preeti to kind of tell the doses age-wise. Less than 2 years, it's 400 to 600. I have to still check that. For pregnancy, as Dr. Usha said, 4,000 to 6,000. I have a little different view on bolus doses, because I think more and more evidence that very high bolus dose can increase, in fact, falls and fracture. There was a study, and therefore smaller doses, in fact, even daily dosing has been shown to maybe improve outcomes like respiratory tract infection, etc. So people are now moving from even monthly to daily doses. So there are some trials about that. So injectable doses comes with its own sets of problems of overdosing, and that is happening more and more in our experience. So many cases, because over the counter these medicines are available, there is a panic when they see those low reports and start taking too much of and this is especially happening with parents of doctors. So most of the cases of hypervitaminosis D I saw is from usually doctor families. So that's very unfortunate. So it's important to emphasize not to give injectable unless there is malabsorption or something, and stick to oral, because then the risk of toxicity is low. Toxicity is reported, although literature worldwide says that it is quite low, but I think in India more and more cases of toxicity are being reported, hypervitaminosis D. Yeah. So
I just wanted to add, I agree with you, Bina, that oral vitamin D is the safest and also reaches the level. So about 100 IU kicks up the level by 1 nanogram. That's their calculation. And so studies have shown that whether you do 60,000 or 2,000 a day, or it takes you up to the level that you want in terms of vitamin D levels. Ultimately it does that. So it is the safer, gentler, smoother way of doing it is to do it orally. Just saying that you reserve the parenteral for an occasional patient with, let's say, with malabsorption, or an occasional patient who, because of some compliance issue or some very severe vitamin D deficiency, that they've been brought in a stretcher or something, and they have to go somewhere far. And so it's for like a niche group of people, and pretty much for everyone it should be oral. And the oral can be daily, or it can be weekly, or even monthly for maintenance.
So, Dr. Beena, let me come to the next question. So, if we say that, and as we discussed, the prevalence of vitamin D deficiency is really high in our country. So, do we really need to do a test at all? And let me quote some figures. I just read something that the average cost of maybe treating somebody for vitamin D deficiency for a year would be not more than 500 rupees, while a single test of vitamin D would be maybe 1,000 rupees. So, what are your thoughts on that?
Yeah, agreed. So I think it feels, number one, screening for vitamin D deficiency using 25-hydroxy-D is an expensive thing to do. It's a public health approach, and probably not required, inefficient also, because we may as well supplement everyone with 2,000 units a day, high risk 4,000 units a day, and it will do the job quite well. But still there is a lot of, again, debate in literature about the benefits versus of testing. So I think I would answer this by saying that in our country, in our setting, maybe high risk testing strategy can be used carefully. If it's still not like if the test is expensive for someone, we don't need to necessarily advise it. Someone asked me, how do you recommend weekly versus monthly dose if you don't have a baseline level? So there is a study which shows that lower the baseline level, more rapid is the rise. It's not a linear rise. So if someone has deficiency, the same dose, to giving 2,000 units daily would still cause a good enough rise. Whereas if someone starts at a little higher level, it will be a flatter spike. So there is a relationship with baseline 25 OHD and rise in vitamin D. So having a uniform approach of giving maybe 60,000 monthly to everyone, whether deficient or non-deficient, over a period of time will reach a steady state level. So that is one approach. Or maybe we can recommend testing, especially for pregnancy. So the reason behind suggesting tests to those who can afford, of course, is that it probably increases the supplementation rate, or it probably makes them more conscious of the deficiency and treat it. For example, pregnancy is one condition where we may consider a baseline level and try to bring it up to 40 also. And the recommended target level is also probably higher, considering the association with preeclampsia and gestational diabetes and preterm delivery. So that is one. Obesity, for example, because the relationship between supplementation and rise in vitamin D changes remarkably, because it's mostly sequestered in fat tissue, and relationship. Sorry. So I'll quickly finish that. So obesity, pregnancy, other high-risk conditions like chronic diseases, chronic kidney disease, the requirement is very high. We did a study that weekly doses just did not increase 25 OSG over a period of 6 weeks. So they need a much higher supplementation, and there is always a fear amongst nephrologists, especially, to supplement vitamin D with the risk of calcium going high, etc. So high risk strategy, screening strategy might be helpful, because we don't have much time, Tejal. There was also a question regarding this. So I think, would you want to comment on what are the various diseases with which vitamin D deficiency is associated? And what is the evidence?
Yeah, can I just add one more thing to Tejal's question on when you would test? I have a simple approach, clinical approach. One is as a therapeutic strategy. If you are using it as a therapy, somebody is coming in with aches and pains, muscle catches, fatigue, and you are linking this is the diagnostic test for this symptom,
Condition.
and you should test. The second is, of course, 50% of people with osteoporosis have an osteomalacic component, and you must know the level because one, the BMD itself might improve significantly, and second, you can't use a bisphosphonate or denosumab without optimizing vitamin D levels. So these two for sure, and only you know, as you know, Bina has, if we want to do anything without measuring vitamin D, I would at least get a calcium, because you don't want that one-off patient with hyperparathyroidism. I know we are going to discuss that soon, hyperpara and burn our fingers. So these are the three places that in my clinical practice, I do vitamin D, not otherwise.
Right, and they're very good points, ma'am, especially hyperpara. We have burnt our fingers too as well with this. So that's one thing we all agree on. So, so Bina, the question you asked me is about the association of vitamin D with various diseases. Then yes, definitely type 2 diabetes, cardiovascular disease, cardiovascular mortality, and reduction in autoimmune conditions, longevity are all the associations that vitamin D has. And in the last 2-3 minutes, I'm just going to talk about the intervention studies. So there have been big intervention studies, a lot of discussion on this. They're published in NAGM and all the big places. Now, there's a lot of criticism of these studies. So if I can just tell you overall, what they found is that vitamin D supplementation does not reduce the risk of type 2 diabetes, does not reduce the risk of progression of prediabetes to diabetes, did not reduce cardiovascular disease, nor does it reduce mortality. So that is overall what all these studies told us. However, there's a lot of controversy with that, because if the subgroup analysis was done, what they found is that in certain people, yes, there was a benefit of treating with vitamin D, especially older people, people of different race or color, and things like that. The other most important criticism of these intervention study was that the same dose was given to everybody, irrespective of what their baseline vitamin D was. So most of the supplementation was done in people who actually had pretty normal vitamin D levels. And then in the subgroup analysis, those with lower vitamin D levels who received supplementation, it was beneficial. And in those who had normal vitamin D levels who received supplementation, it was not beneficial. Dr. Bina, do you want to add something to this, please?
I agree. So the problem with all these nutrient supplementation trial was that to begin with, they did not fulfill the criteria of nutrient deficiency. They did not do that as a baseline, and they didn't select patients for that. And plus, I think sample size problem was always an issue, because considering that these were not highest of risk for CVD and type 2 diabetes, so you would need a really, really large sample. So inadequate sample size, improper selection of patients, and COVID-19 also, there are trials which actually show improvement with intervention, and that is one thing. So innocent bystander versus a treatable, modifiable risk factor, that controversy remains. However, this being an inexpensive, most likely a safe therapy, I think there's no harm in trying and increasing overall 25 OHG level as a population to at least 30, if not 40. If I think I'll
Dr. Bina and Dr. Tejal, I think the controversies are heating up. So I think we continue that discussion time, and we need to give some time to our next speakers. So we will carry forward this discussion in our Q&A session also. I'm sure there are a lot of questions still to be answered. So moving on to our next, Madam, would you like to take it ahead? Usha ma'am, yeah.
To comment on this or to move on to the next?
You gave a final comment on this?
No. I think this has been such a lively and wonderful discussion. These are all, burning questions that, people, not just academicians and researchers have, but people at the ground level practicing have a lot of questions. So they were all addressed beautifully, and we'll take up some more time in the discussion and discuss this. Yeah.
Sure, ma'am. So now we move on to the next one. So our next speaker would be Dr. Sunetra. So would you introduce her, ma'am, or you want me to introduce her?
Please introduce her.
Yeah. So can I have Dr. Sunetra's CV slide, please? I think we had a wonderful discussion now, and we have another interesting 2 sessions on difficult case handling. And one is going to be on by Dr. Sunitra. She's going to speak on patients with tertiary hyperpara, in patients with renal disorders where you really can't operate them and they are unfit for surgery. So can I have Dr. Sunitra's slide, please? Yeah. So we have a young endocrinologist, a new budding one, and she's a dynamic lady from Calcutta. And she's Dr. Sunitra Mondal. She's presently consultant endocrinologist at Health World Hospital, Durgapur, postdoctoral senior resident from IPG MER, Calcutta. She has ESI AV Gandhi Award to her credit. She has a university gold medal in the DM examination. She is All India first runners-up and zonal winner in the ESI TISA Award, other awards and papers, numerous posters and publications in international journals and chapters in nearly 14 books. So I think she has lots to her credit at this young age. So over to you, Dr. Sunitra, for your presentation.
Thank you so much, madam, for that very kind introduction. I hope my slides are visible.
Yeah. Yes, they are.
Good evening, and I thank the organizers. I honestly thank the organizers for this opportunity. So the next 15 minutes, I'll be trying to endocrinologize tertiary hyperparathyroidism, which is primarily a disease of the endocrine surgeon. So I start with the story of a 78-year-old man living with type 2 diabetes, coronary artery disease, post-CABG, severe left ventricular dysfunction, on maintenance hemodialysis for the last 8 years. And he has a recent history of constipation and loin pain. Clinical examination otherwise was unremarkable. These are his biochemical parameters at admission: serum calcium at 12.8. And his current medication lists include basal bolus insulin with linagliptin, antiplatelet, statin, ARNI, loop diuretic, and beta blocker from his cardiologist, iron and darbepoetin for his anemia, and he was receiving phosphate binder, cholecalciferol, and calcitriol for his CKD-MBD part. Now, looking serially at his CKD-MBD parameters, there has been a consistent increase in his serum calcium as well as serum parathormone. He has osteoporosis at both his at all these regions, and this is in spite of the fact the lumbar vertebra BMD was low, in spite of the fact that he was having some aortic calcification, and he now has a urolithiasis as well. System may be scanned, localized a parathyroid adenoma in his retrosternal region adjacent to his thyroid isthmus. So as we know, tertiary hyperparathyroidism traditionally is diagnosed by high PTH levels in the background of high calcium and a normal to high phosphorus. The clinical implications and complications are very similar to primary hyperpara, excepting the fact that there is a particularly raised cardiovascular risk and risk for vascular calcifications, because these patients also have a prolonged underlying serious comorbidity like a CKD. And looking at the causes of raised PTH in CKD, there are manifold: raised phosphate, low calcium, low calcitriol, indirect effects of FGF23, of course. And initially, there is a polyclonal proliferation of the parathyroid cells. Slowly, they go on to have a monoclonal proliferation with decreased expression of calcium sensing receptor, VDR, resistance to FGF23. And finally, there is additive action of many growth factors, cyclin D1, and they go on to have autonomy. So the pathogenesis itself explains the options that we have for medical therapy in renal hyperpara: reduction of the serum phosphate, be it with dietary restriction or with binders, vitamin D and vitamin D receptor activators, and agonists at the calcium sensing receptor. Now, the recent KDIGO CKD-MBD guidelines, they focus more on restricting animal proteins and avoiding processed foods as a means to decrease dietary phosphate, rather than grossly decreasing all protein-rich foods. Regarding phosphate binders, they can be calcium-based binders, most commonly used, but yes, they do have an increased risk for vascular calcification and cardiovascular mortality. Calcium-free phosphate binders could be either anions bound to other cations, say like aluminium, lanthanum, and iron, which could accumulate in tissues causing toxicity. And there are polymers like sevelamer, which are possibly the safer option. And there are some novel drugs that inhibit active intestinal absorption of phosphate, like tenapanor, which has shown very promising results. So 2017 KDIGO guidelines versus 2009, there are gross changes. First, the focus is on serial assessments of phosphate, calcium, and PTH, and not just a single raised value. Second, the need to treat phosphate is only there if there is high phosphate and not forcibly to keep it within the normal limits. And decisions regarding binders are only to be taken if the phosphate levels are progressively or persistently raised. And calcium containing phosphate binders should be restricted across all severities of CKD and not only if there is hypercalcemia. Finally, they also focus on avoiding hypercalcemia only rather than going on to treat even mild and asymptomatic hypocalcemia in order to keep it within normal range. Talking of vitamin D receptor agonists, we know they act at the transcription level. Calcitriol, commonly used but does have the potential to cause hypercalcemia. More selective agents, they can control PTH levels with more modest effects on serum calcium. And there are trials now which have shown that these agents do not actually have any cardiovascular benefit with regards to cardiac surrogate markers. And there are some extended release calcifidiol, which reduces metabolism of 25 and 125 dihydroxy vitamin D to cause up to 10% reduction in IPTH. So again, the 2017 guidelines, calcitriol and vitamin D analogs are not to be routinely used, but restricted to advanced CKD with severe and progressive hyperparathyroidism. Calcium mimetics, we know agonists, not only agonists, but also allosteric activators of the calcium sensing receptor. So their action do not necessarily depend on the expression levels, and activation of the CASR can also increase vitamin D receptor expression, which becomes particularly important in tertiary hyperpara cases. So for sinacalcet, we now have good amount of data in renal hyperpara following of the EVOLVE trial, in which although there was a non-significant reduction in the primary composite endpoint of all-cause mortality and multiple cardiac outcomes, but when the analysis was adjusted, taking into account the effects of parathyroidectomy, transplant, non-adherence, etc., the benefit was actually significant. There was some suggestion that it was more effective in elderly population. And on post hoc analysis, there was a significant reduction in the risk of tertiary hyperpara and the need for parathyroidectomy. Of course, there is some increased risk for hypocalcemia. High discontinuation rates due to GI side effects and cost is definitely a factor. Although we know that sinacalcet, we do not expect a lot of improvement in BMD, but it has been found to reduce bone resorptive markers and even serum FGF23 levels. In combination with vitamin D, sinacalcet can attenuate progression of coronary artery calcium accumulation. And in the bona fide trial, those with high bone turnover disease had actually normalized their bone histology following the administration of sinacalcet. So again, calcium mimetics have now made their place as a first-line drug along with the other agents wherever reduction of PTH in CKD is considered. But as of now, the KDIGO does not recommend any one agent over the other. Yes, there is a genuine concern of QT prolongation with sinacalcet therapy in hemodialysis patients. And bone health, we now know that FRAX with or without BMD and the femoral neck T-score can all predict poor bone health in CKD as well as in those without. We have data from post-hoc analysis of alendronate, even teriparatide, raloxifene, and denosumab, but not much data in advanced CKD. And recent guidelines, bone biopsy is not recommended before starting bisphosphonates, thanks to all this data now. So coming back to our patient, elderly man with type 2 diabetes, CAD, severe left ventricular dysfunction, tertiary hyperpara. Of course, after explanation of his risks, he denied surgery. So his calcium containing phosphate binder was changed to sevelamer. He was started on low dose sinacalcet with close cardiac monitoring. Calcitriol and cholecalciferol were continued, and around 4 to 5 months later, his calcium and PTH had fallen, but we did not really do anything for his osteoporosis and his urolithiasis. So now that today I have the privilege of having so many teachers and seniors, I would like their opinion on what else we could have done for his osteoporosis. Of course, teriparatide is not an option, but could we have given denosumab, given his CKD5D status, and whether his thiazide should have been replaced. Thiazides should have replaced his loop diuretic. Yes, there are some novel calcium mimetics like ethyl-calcitide given IV every other day, so better compliance. Evocalcet with better bioavailability, so lesser GI side effects. And comparative study has shown highest PTH lowering with ethyl-calcitide. Of course, with that comes highest risk of hypocalcemia. And GI side effects were most prominent with sinacalcet. Coming to my second case, who is a 55-year-old lady with type 1 diabetes. She underwent renal transplant around 2.5 years back. She was postmenopausal and presented with recent onset drowsiness. And her calcium levels were as high as 14.3. Her current medication included insulin infusion pump, tacrolimus, mycophenolate, and low-dose prednisolone for his immunosuppressive regimen, statins and ARB and beta blocker. She was already receiving calcium carbonate, calcitriol, and cholecalciferol from her pre-transplant period, which was continued. She was also on cinacalcet 30 milligram during her pre-transplant period, but she stopped it by herself around a year after transplant. So again, serial estimations showed that there was a substantial increase in her calcium and PTH levels after she discontinued cinacalcet. She again has osteoporosis. Cesta may be localized, a parathyroid adenoma in her mediastinum below her right bronchus, which is definitely a very difficult area for surgery. So as we know, post-transplant PTH and calcium levels can stay high at least till 12 months after transplant. And so any decision for the need for parathyroid lowering should only be taken at least a year after renal transplant. The KDIGO focuses a lot on the frequency of monitoring of these parameters based on the post-transplant CKD stages, but there is insufficient data as of now to guide the treatment after first 12 months, especially for bone health. Indications for surgery in tertiary hyperpara post-transplant are again not very clear-cut, but of course, anybody with severe hypercalcemia, persistent hypercalcemia, and symptomatic hyperpara with fractures, with mental status changes, with renal calculi do merit surgery. There are studies comparing surgery to cinacalcet, and even subtotal parathyroidectomy has shown greater reduction in PTH, greater improvement in bone mineral density, of course, is more cost effective, but there were no differences in calcium lowering, vascular calcification rates, or renal function decline. And long-term data from the same study showed the rates of normocalcemia, graft function, and fragility fractures were similar in both the groups, though the recurrence, if any, was observed only in those receiving cinacalcet. Now, this was an interesting study in which the authors have shown that pre-transplant cinacalcet could actually reduce significantly the risk of post-transplant hyperparathyroidism, but it must be kept in mind that cinacalcet can also mask post-transplant hyperparathyroidism. So any measurement of PTH should be taken at least 2 to 4 weeks of calcimimetics. There is some evidence of resistance to cinacalcet, especially if the parathyroid adenoma size is more than 1 centimeter. Coming back to our second case of post-transplant tertiary hyperpara presenting with hypercalcemic crisis. Yes, she was initially managed with fluids, loop diuretics, and a short-term subcutaneous calcitonin. She was given a dose of zoledronic acid, and cinacalcet was restarted, and slowly the dose was increased to 60 milligram twice a day. But 3 months later, she presented with symptomatic hypocalcemia, likely because the combined effects of zoledronate and cinacalcet, which, however, leveled towards normal after the cinacalcet dose was reduced. So again, I have the privilege of asking my teachers, where did we go wrong? Was it a prudent decision to give both together? And what could we have done for this person's bone health? Coming to my last case, a 34-year-old man with X-linked hypophosphatemic rickets, receiving a rather high dose of oral phosphate for his age and calcitriol 0.5 microgram a day, very infrequent clinic follow-up. And he now presented with a picture consistent with tertiary hyperpara along with nephrocalcinosis. Sesta scan localized a left inferior parathyroid adenoma along with some uptake in his left horn of thymus, both of which were removed. And intraoperative PTH monitoring were consistent with a very successful surgery. However, 6 months post-op, he again presented with the recurrence of his hyperparathyroidism. As we know, though, there are options of total parathyroidectomy with or without autotransplantation, subtotal and limited resection, both all having good success rates. But limited resection, even with bilateral neck exploration, there is a high rate of recurrence, especially due to ectopic glands. And intraoperative PTH and intraoperative gamma probes can reduce the recurrence rate, but of course not to zero. And this study of more than 100 patients with X-linked hypophosphatemic rickets showed a quite high prevalence of tertiary hyperpara, and even after surgery, the rates of recurrence was as high as 75%, mostly because of multi-gland hyperplasia, and 5 patients who were attempted cinacalcet did not quite respond well. And we should remember that it is not just excess phosphate, it's not a raised FGF, there is also the fix-mediated PTH inactivation, which can cause the hyperparathyroidism. So our patient with X-linked hyperphosphatemic rickets, tertiary hyperpara, and failed surgery, we repeated localizing studies, but we could not find any new lesion. He refused a repeat exploration surgery. So his oral phosphate and calcitriol were temporarily discontinued. We have plans to restart it at lower doses of phosphate. Just to mention, burosumab do not have any benefit with regards to tertiary hyperpara, and cinacalcet, we have very insufficient data in this setting. So another option for these patients, if unfit for surgery, is chemical ablation. Way back in 2003, Japanese guidelines had suggested enlarged parathyroid with nodular hyperplasia could be selectively destroyed with ethanol, whereas other glands with diffuse hyperplasia could be managed medically. Injection of calcitriol is another option. There is good response up to 6 months, and complications are mostly transient. So medical therapy still remains a second line to surgery in tertiary hyperpara. Calcium mimetics are a safe and effective option. And of course, as an adjunct, along with optimization with vitamin D, VDRA, and agents for bone protection. Special thanks to Dr. Tritiman Maitra for the images. He's a very dynamic endocrine surgeon in Kolkata. Thank you so much.
Wow, Sunetra, that was awesome. Amazing. Let me see if I muted. No, that was amazing. All the 3 clinical scenarios you presented were brilliant. I invite others if they have questions, but I just want to say that all 3 have a sort of a common thread as well, right? So as far as the first 2, when we see patients with CKD and step by step handle the phosphate retention, supplement calcium, make sure we optimize the vitamin D, and still if their calciums and their PTHs are high, or other bone disease is starting to happen, renal osteodystrophy is progressing, then I think all those options that you listed are wonderful options. The usual rationale is wait for transplantation, because post-transplantation, the parathyroid problem resolves in a lot of patients. So we hope to get 2 birds with 1 stone, like you transplant and take care of both. But then, of course, there are others who continue with their problems post-transplant as well. And those are the ones we end up thinking of calcium mimetics or parathyroidectomy. So I think you outlined everything beautifully. And I don't think any of those patients you handled badly at all. I think decisions are taken at the time when you're presented with the clinical problem. Maybe in the second patient, use of zoledronic acid and the cinacalcet lowered the calcium significantly. Maybe that's the only thing that I could think of, one at a time, because we know what happens with IV zoledronic acid. So I think you managed all these patients remarkably well. So great. And I open this for discussion from others as well.
I think I agree with Madam, and I just have a comment to make regarding my own experience in such kind of patients. So I have 2 patients of CKD who we can't really operate. They are proven adenoma with high PTH. We are trying to control their calcium alone and try and keeping it at the upper range of normal. We have managed to keep it with cinacalcet and denosumab combination. So these are requiring a high dose of cinacalcet, not a smaller dose. They're requiring nearly 90 milligram per day. And denosumab, they're trying to maintain at the higher range of normal, and they at least the hypercalcemic manifestations are reduced significantly. So I think, I don't know how long we would be able to maintain. There's very scarcity of literature on combination of these 2 therapies, but I am thrilled with the presentations that you have given. I think it's a varied spectrum. It's a good learning for all of us, in fact, and I'm glad to be here today to listen to all this. So this is open for the other viewers and audience question. There is one question raised by Dr. Gagan, and she's saying that what should be the targets for serum calcium, phosphorus, and PTH in advanced CKD? So do you have any defined targets?
Ma'am, as per the recent KDIGO 2017 guidelines, they have mentioned we should aim at avoiding hyperphosphatemia and avoiding hypercalcemia rather than forcibly keeping it within normal. And PTH, again, 2 to 9 times, till 2 to 9 times of the normal range can be allowed for the CKD patients, advanced CKD patients.
Yeah.
And what is the risk of adynamic bone disease in case they are overtreated?
That is of course there, but we know that neither PTH nor any of the bone turnover markers, nothing can predict apart from bone histology that this is going to be a low adynamic bone disease. So our target, of course, we should not overtreat, but when it is necessary, we should give the treatment.
Thank you so much. And I think for the lack of time, we move on to the next presentation. Thank you, Dr. Sunetra. And our next presentation is by Dr. Jayashree. And Dr. Jayashree will be talking on another difficult case scenario where you have non-localizing parathyroid disease and what is to be done in such a scenario. So can I have her introduction slide? Yes, Dr. Jayashree Sambakar is a very good friend of mine. She's a DM from KM Hospital, Mumbai. She was lecturer in Department of Endocrinology at Nair Hospital, and she's fellow Department Endocrinology at Hammersmith Hospital, London. She's practicing at Nagpur at Getwell Hospital since 2001. She's the director of Center for Metabolic Disease and Osteoporosis, and she's a part of numerous research projects in osteoporosis and diabetes. So over to you, Dr. Jayashree, for your discussion.
Thank you, Vaishali. It's really a pleasure and privilege to be a part of this program. I hope you are able to see my slides.
Not yet.
Not yet? Okay.
Yeah, you'll have to share.
Yeah. And I really appreciate why this, the idea behind this whole,
yeah, we can see
symposium.
the screen. Just make it full screen.
Yeah, I'll do that.
Yeah.
Oops.
Yes, it's visible now.
It's visible now?
Yeah. Just make it full screen.
Yeah, I'll make it. I'll just go to the first slide and just 1 second. I really like the idea behind this symposium because, dealing with the difficult cases is the most important thing. We should be able to, give answers when the patient is sitting across the table. And that is what really makes things difficult for a clinical clinician. Today, I am going to talk about hyperparathyroidism, primary hyperparathyroidism, where the scan is negative. So you have diagnosed a patient to have biochemically primary hyperparathyroidism, but the scans are not localizing the disease. And it is here that the real test comes. We all agree that hyperparathyroidism has really been changing its clinical signature over the last few years. When we were learning, we used to be thrilled to see the skeletal havoc which the PTH used to cause. And we used to, be very happy seeing those things which we have read in the textbooks on those skeletal X-rays. But as the introduction of multi-channel analyzer and all, we all know that the asymptomatic variety is increasing a lot. And even in Indian data, almost 30–40% of hyperparathyroid patients are are being picked up in asymptomatic stage. Has the disease really changed? No, I don't think the disease has changed. We have advanced. We have learned many imaging modalities, and we are surely learning to diagnose that disease earlier. The diagnosis is definitely becoming less exciting as far as the clinical, examination and all is concerned. But surgeon's job is really becoming difficult because we are diagnosing them quite early. We are diagnosing them at asymptomatic phase, and we are diagnosing when the adenoma size is really small. A person who is coming to you with a wide skeletal involvement, you don't really have to convince the patient for surgery, because he would be more than happy that you have found the cause, and he would be very, very willing to get that adenoma operated. But when he comes with a totally asymptomatic, no symptoms at all, only calcium which is raised, PTH which is raised, and the doctors which are being anxious about treating hyperparathyroidism, it becomes really a huge task to really convince those patients that, okay, that adenoma needs to come out. We are definitely doing a better job, but surgeons' job is really becoming difficult day by day, especially because minimally invasive surgeries is also in demand. What is the implication of not, not localizing the disease preoperatively? There is a reluctance in the form of referring is also less, as I said. Surgery, as we know, is the best curative treatment option for primary hyperparathyroidism, and hence we must make all the effort for precise preoperative localization so that we achieve a successful outcome. Primary hyperparathyroidism diagnosis is really biochemical, isn't it? So why we should make so much effort to localize that adenoma? Localization actually is a roadmap for surgeon. It really makes the surgery very, very focused. The dissection would be very focused and we'll get a good outcome. It also helps you to localize an ectopic adenoma, and especially in patients with second surgery or recurrent or persistent disease, it really is helpful to localize where the culprit gland is situated. And hence the localization methods I would go into very, very briefly would be preoperative or non-invasive radiological methods, which could be anatomical in the form of USG, CT scan or MRI, or it could be functional in the form of system-AB scan or colon PET. Very, very rarely invasive PTH sampling has also been tried. And of course, intraoperative PTH has become a surgeon's friend like anything. Whenever the adenoma is not localized, the is scan negative, the first thing which comes to always comes to my mind is my diagnosis correct? And it's always there to confirm. It's better to confirm the diagnosis. Am I using the correct modality for imaging the gland, or is the gland ectopic, or is it a multiglandular or hypoplastic disease and hence it is not being localized on the scan? So these are the common reasons for non-localization. I'll just go through quickly through one of the case which I saw recently. She was a 60 years postmenopausal female who was known case of diabetes, hypertension, and had recurrent renal calculi with recurrent episodes of urosepsis. She was basically referred to rule out any endocrine cause for renal calculi. And as you can see, she has primary hyperparathyroidism, biochemically proved. And when I did her scan, this was a scan which was showing absolutely no uptake at all. But USG was showing a nodule in the right inferior pole of thyroid, which was not really different from thyroid, but it was present there in the inside in the thyroid. But scan was absolutely negative. So we also did a CT scan, and which just confirmed the USG findings, and it was not leading me anywhere. The patient was not affording PET scan. So what needs to be done? What are the options? PET scan availability and affordability, always an issue, especially a place where I am practicing, a second tier city. I get patients who do not afford PET scans so easily. CT guided FNAC, a huge question mark. But of course, we have a few case reports where they have done FNAC, and we all are aware that FNAC has its own dangers of seedling whenever along the needle track. So it is not really recommended. So for this patient, we had a discussion with radiologists, with surgeons in my hospital, And we went ahead with bilateral neck exploration. And this is what we found to have a huge parathyroid adenoma, which was actually sitting inside the thyroid. And histopathology was not showing any vascular or capsular invasion. So this was a patient who had scan negative because the adenoma was situated inside the thyroid. Patient is very happy, and post-surgery, her calcium, phosphorus, and PTH is absolutely normal. So another good successful outcome. Now, there was always questions why the system AB scan did not localize. To have some basics like system AB, which is uptaken in the tissue, which is dependent on the mitochondrial density, and this mitochondrial density is high in oxyphil cells. So if your adenoma is poor in oxyphil cells, then it fails to get localized in the system AB scan. Many times the cystic lesions, which are also very poor in oxyphil cells, can be negative on the imaging. If the adenoma has lot of apoptosis or lot of necrosis, then it can give a false negative imaging. There are few studies which show that if there is increased microvascular density and the presence of P glycoprotein, then it really leads to rapid washout of the contrast, and hence you get negative imaging. Conditions which really reduce the sensitivity are the multiglandular disease of thyroid, or if you have thyroiditis with reactive lymph nodes also, then the scan sensitivity reduces. If this lesion is less than 1.3 centimeters, also it becomes very difficult to locate the gland. If you combine sonography with system AB, with 90% of parathyroid adenomas would be localized. If they are not localized, you should really make an effort to go and get others modalities also, so that we are successful in localizing the adenomas. 20 to 30% of patients still remain unlocalized even after sonography and system AB scan, and hence we have to go further and explore the further advanced further modalities of imaging. And 4D CT scan, which is a very useful technology, very high resolution, and hence it can detect very small glands. 80% of lesions which are negative on system AB and USG can be detected by 4D CT scan. And hence it is very useful when both first investigations are negative. 60 to 85% of multiglandular disease is also picked up, and it is also very helpful whenever there is redo surgery or second surgery, because the anatomical and spatial resolution is very good. Disadvantage is high radiation dose, availability, and cost. Of course, nowadays when PET is available and there are a lot of guidelines regarding use of PET, choline PET has been described as a choice, PET of choice, because choline is taken up by phospholipids in the cell walls of hyperfunctioning parathyroid cells, and you get more SUV in the adenomas versus hyperplasia. Whenever you have a negative or a discordant results with system AB and USG, choline picks up almost 70% with sensitivity of 70% and positive predictive value of almost 94%, which is an excellent value. And we have some data from the St. John's Hospital, Bangalore, who they have utilized methionine PET and had an excellent results in patients who were scan negative with sonography and system AB scan. In fact, the most recent European Journal of Nuclear Medicine guidelines, they are advocating PET as a first modality of imaging primary hyperparathyroid glands rather than going for system AB. This is the recent guidelines, but again, availability and cost will have to be checked in. So once we are done with traditional imaging, which is negative, we must go and towards the recent additions in the form of PET. Third level of investigations to localize are very invasive kind of things, which I have read only in recent literatures. And though described are the angiographically, they select the venous sample of inferior vena cava, internal jugular vein, bilateral internal jugular vein, and collect sample of PTH so that they can lateralize either on the right side or left side, and then have focused dissection or minimally invasive surgery. There are some also reports of bilateral internal jugular venous sampling to find out, which side of neck has to be explored. There are a lot of reports in ENT journals and ENT literature about this kind of approach. I thought it's just like doing the inferior petrosal sinus sampling for PTT, doing PTH sampling for in internal jugular vein to really lateralize as to which side of neck needs to be explored first. Intraoperative PTH assay, I think this has become a third eye of surgeons, especially with the advent of minimally invasive surgeries, because it has really increased the success rate. And with the availability of rapid PTH assays, it has become a real advantage for MIP surgeons. PTH dropping more than 50% at 10 minutes indicates successful removal of culprit gland. And I would say that if the pre-op imaging helps to direct the surgeon for a focused exploration, it is the intra-op PTH which helps him to terminate the surgery successfully. Localization and stopping the surgery, both can be done if you have a very good pre-op imaging technique. In redo or surgery or patients who have persistent PTH levels, of course, choline CT PET would always be helpful. And hence, I would like to say that first line of investigation should always be sonography and systemically in our setup at least. Whenever 4D CT is available, it should be done. Then second line of investigations would be, if the first line is negative or discordant, then we should go for PET. And third line of investigation would be an angiographic venous PTH collection or intraoperative internal jugular venous collection sampling. But again, these are, I think, very few high volume centers would be doing this, and no experience of all these things. Another interesting case which I saw was a 48 years female who had history of gastrinoma surgery in 2000, papillary thyroid carcinoma in 2019, and total thyroidectomy in August 2019. She was referred with severe bony pains and difficulty in walking, and she was proved to be biochemically hyperparathyroid, primary hyperparathyroid. So this was a case who had gastrinoma, papillary thyroid carcinoma, primary hyperparathyroidism. Her prolactin was normal, and there was no hypoglycemic symptoms or history. So I presume this was a case of MEN1, and I did an imaging with the expectation of a multiglandular or hyperplastic disease, and was surprised to have a very well localized adenoma in the left inferior side of the neck. Again, the discussion in this case was what should be done, whether we should remove her adenoma which was lighting up on the scan, or whether we should do 3.5, because she was a case with gastrinoma and primary hyperparathyroidism. So she had two components of MEN1, and although genetic analysis was not available or not done, this was a case with the presumed MEN1. So we discussed everything with the patient and with the surgeon and radiologist, and went ahead with subtotal 3.5 gland removal. She was also explained high incidence of thymic carcinoids, and in the same sitting, her thymus was also removed. And she also had a successful surgery with pre-operative PTH levels being 797 to post-operative almost to 24. Another interesting case was a 69 years female who was admitted actually for COVID pneumonia, and she had convulsions in the hospital. Her metabolic screen was done for convulsions, which showed calcium, which was 11, and PTH of 560. So she had primary hyperparathyroidism. Her vitamin D, urea, creat, renal parameters were totally normal. She was managed, her hypercalcemia was managed with IV fluids, steroids, and she unfortunately needed tracheostomy and artificial ventilation for her management of COVID pneumonia, and she had a prolonged stay in the hospital. So during that period, we maintained her eucalcemia. We could get her USG and CT scan done, which showed a very non-significant nodule in the thyroid on the left-hand side. This was her scan, which we did after she was discharged. And again, her scan is absolutely negative. I cannot localize anything on the scan. She and her family were totally exhausted. I can understand that. And they needed some breathing time before further investigations were planned. And hence she was started on Sinacalcet, initially to start with 30 milligram once in a day, increased to twice a day. She also had a DEX-approved osteoporosis, so alendronate was added to that. But the question is, at 69 years of age, she has osteoporosis, and she is already on Sinacalcet, alendronate. How far should I go in localizing the culprit gland, and what will I achieve after surgery as compared to medical therapy? So I would just like to say that although Sinacalcet is not a medical equivalent of surgery, although is a curative therapy, we have to sometimes give breathing space to the patients and control their hypercalcemia with Sinacalcet. It really normalizes calcium, but we know that it does not normalize bone density or PTH. If osteoporosis and future risk, which was the concern in her, that's why alendronate was added. And if calcium and osteoporosis is not the issue for treatment, then maybe no pharmacological treatment will be given for non-localized patients. So I would just like to conclude by saying that be very sure about the biochemical diagnosis, especially when your scans are negative. Go ahead and rule out hypocalcemic, hyperuricemic hypercalcemia, so that you are not missing out on that hypocalciuric hypercalcemia. Make all efforts to do all anatomical plus functional imaging whenever possible. Use intraoperative PTH assays if they're available. Be always on the lookout for familial main cases. Treat medically till you localize your culprit gland. And surgery is the cure for primary hyperparathyroidism. And medical treatment should not replace surgery. Thank you very much. And at the end, Usha ma'am, as I told you, I have few questions for you yourself. Like if I give bisphosphonates as a medical therapy, like in this patient, and after 3 months or so, she agrees for surgery, will her bone recovery be affected because of alendronate which I have given her?
I don't think so, Jayashree. First, very quickly, let me just, I don't think we have too much time, right?
Yes,
Vaishali?
ma'am. Yes, ma'am. Please, your
just
expert
1
comment
minute.
first. Yeah.
So a famous surgeon said the best localizing procedure is to localize a good parathyroid surgeon. Okay. So when you take all patients with hyperparathyroidism, actually we don't need any localizing procedure at all. I'm just talking about the uncomplicated, straightforward patients. You just need a good parathyroid surgeon. The decision to do an imaging is after the surgical consult. So afterwards, if they're going to do a minimally invasive or it's a redo procedure, so it's more a roadmap for them than for us to make a decision on surgery versus medical management. So it's first a surgical decision and then a roadmap for them, and then whether we do sesame B or any of these fancy things. So usually a good surgeon should be able to explore and find it. In those unusual circumstances, definitely we need to deploy one of the tests that we have talked about. So brilliant cases, brilliantly handled, I must tell you. And as far as the use of alendronate, and then if the patient is willing to undergo surgery, and like you yourself said, surgery is curative. And that would be the best thing for this patient. And what you can do is maybe, definitely take them off the bisphosphonate prior to the surgery. And it's going to take a while for the whole resorption markers to change and things like that, but it will, just on the basis of the parathyroid tumor having gone, the bone will recover fast. So I don't think this should put a hold on
surgery.
Okay, Vaishali, shall we?
Yes, ma'am. I think I'll go wiser today, a shade better than what I was, with your pearls of wisdom and fantastic presentations by all the speakers. So I'm a shade more wiser now. So thank you so much for that excellent session. And I think we move on to another interesting one. And over to you, Shaila, for that. I'm sorry, we were overboard by 10 minutes, 10, 15 minutes. Yeah.
That's okay. I think that's absolutely okay, because after listening to all these fantastic speakers and ma'am's comments, I think it's all been worthwhile. So a big thank you, ma'am. A big thank you to everybody. It's been an absolute pleasure listening to everybody from from yesterday. And I want to use this opportunity before I go to the next session to say a big thank you to everybody. A big thank you to everybody who, practically just with a phone call agreed to be a part of this meeting. So hats off to all you fantastic women. And to be very honest, hats off to all those fantastic men who have supported us, because we are not, by any point of time, we are not being classically feminist, if I'm allowed to use that word on this forum, because believe it, I mean, the president of ESI, including all the executive committee members, agreed at the drop of a hat to allow us to be to do this meeting. So I think yes, ma'am, allowed us. Allowed us means we had to, ma'am, we have to go them with an SOP. There's an SOP involved in this.
No, I'm just saying that you're doing a marvelous job, and this is great. But no, don't use the word allow.
I'm sorry, I take back my words. But allow.
I'm just saying that you don't need to be allowed. You are doing a marvelous job.
I take back my words, but the reason I wanted to put this across, ma'am, was that, everybody's been very supportive about the entire concept.
That is completely true.
Yeah, so I don't want to take that away from them also. So my bad, wrong word to use, lesson learned.
So I request everyone to please switch on their cameras.
Sorry, Mintu, you want us all to switch on our cameras?
Yeah, so that I can take a picture.
You can't ignore when Mintu orders, you can't ignore, believe me. I've learned that over the last 2 years. The final word is always Mintu's. So the last session, but not the least, I mean, we have a very, very interesting session coming up over here, where we have none other than Dr. Shaila Bhattacharya, whom we all know as the person to go as far as disorders of growth and puberty goes. And we are going to be now discussing the controversies in growth and puberty. We all again know that ma'am really requires no introduction, but I am still going to be telling everybody that, can you see my screen? Is my screen?
Yes,
yeah,
it's visible.
Okay. Dr. Bhattacharya is the professor, Department of Pediatrics, JJMMC, Devangari, Pediatric and Adolescent Endocrinologist, Shiva Jyoti Clinic and Manipal Hospitals, Bangalore. That's a that's a very, very simple CV she's put up, but we all know, I mean, Madam, as I said, requires absolutely no introduction. So I'm going to hand it over to Madam from here. I am going to be putting the first, ma'am, I'm just putting up the first slide for introduction, because there seems to be something wrong here with my.
While you start doing it, I will start here.
Yeah, please, ma'am. Please go ahead.
Good evening, everybody. I think I would like to thank all the lovely ladies, especially the 4 ladies, Shaila, Gagan, Belinda, and Vaishali, for giving us this opportunity today. And when it was discussed, controversies in endocrinology, and when it was said that it was all in the women's group, there were men joking, is it controversies in women? So there were a lot of discussion going about it, controversies. So we had to tell them, no, it's controversies in endocrinology, but discussed by only the women group. So we have for the first topic, controversies in evaluation of growth hormone deficiency. I think Preeti is very well known to this group. She is Professor of Endocrinology in SGPGI Lucknow, and her research areas are PCOS and GDM and type 1 diabetes. So I hope Preeti will be covering how we can get rid of doing growth hormone testing. Is it only anthropometry would be enough, or should we do all 2 tests, physiological, pathological, everything, or should we just do IGF-1, IGF-BP3, or anything more than that? Over to you, Preeti.
Dr. Preeti, please unmute yourself. Preeti, you'll have to unmute, please.
Yeah.
Thank you.
Is that okay? Thanks.
Yeah, that's good.
Thank you, Shaila. You have set the ball rolling and made my job easier. So I don't have to tell people that what my talk would be. But as you said that, I think the controversies is a very difficult topic, or maybe not a very good title, at least what I think. It is more of confusion, and there's no clarity of how to diagnose growth hormone deficiency. That probably sounds better than just saying controversies. So we know that this is not such a common condition, but it is important to diagnose growth hormone therapy, growth hormone deficiency, because growth hormone therapy in a proven clear-cut growth hormone deficient child or an adult is effective. In children, the primary aim is to give them good growth, and side by side comes all other parameters of growth hormone deficiency are corrected, like good lean muscle mass, and metabolic parameters are better. And in adults, we give growth hormone for all the metabolic abnormalities which are seen in adults because of growth hormone deficiency. But the flip side to this is that an incorrect diagnosis leads to an extremely expensive therapy. I just put in a rough estimate that the cheapest growth hormone which is available translates to about rupees 10 per kg per day, the minimal dose which is started in a proven growth hormone deficient child. So we really have to be very sure of the diagnosis before we put the child and put the family through such an expensive treatment. And diagnosis in adults is even more challenging because they don't have a single biochemical endpoint. In children, we have short stature and an improvement in height, which at least justifies or at least gives us some positive clue that we are on the right track. But in adults, we are not lucky, or we don't have the luxury of having such a biological endpoint. So who are those children in whom we suspect growth hormone deficiency? It is all those children who are severely short, be it on the height SDS or their SD scores according to their mid-parental height, or have a poor growth velocity, or they are showing centile, they're crossing their centile. So that means their short stature or the deficiency is evolving, or patients who have deficiencies in other pituitary hormones like thyroid, adrenal axis, or the gonadotropins, and babies who have neonatal symptoms and signs of growth hormone deficiency in the form of hypoglycemia, micropenis, and if an acquired growth hormone deficiency would be suspected if there has been surgery or an evidence of an intracranial lesion, radiation, or a trauma. So these are the conditions where you would suspect growth hormone deficiency. Then coming to just a brief physiology of growth hormone secretion, which will tell us that what to test to diagnose growth hormone deficiency. And here comes the confusion of which parameter to test. We know that growth hormone secretion is normally a pulsatile secretion. Mostly it is in the night and in the stage 3 and 4 of sleep. And the levels are undetectable during the day. So what is the role of measuring a random growth hormone? Absolutely none other than in the neonatal period. So in the neonatal period, a random growth hormone value of more than 7 rules out growth hormone deficiency. So then if we can't do a random measurement, so what to do in a pulsatile secretion as in any other hormonal test? Does the 24 hours growth hormone profile help us, or a urinary growth hormone? All these have been tried in, say, in the time periods of 90s and early 2000s. The 24 hours growth hormone profile has been done, in which the drawback of this is that you need a deconvolutional analysis and you actually have to bleed the child every 20 minutes. And as we saw that the maximum secretion is in the night, so the child cannot sleep, and then you have to actually bleed the child every 20-15 minutes during the night as well. Then these 24 hours growth hormone profile, there is a marked overlap between the growth hormone deficient children as well as growth hormone sufficient children. This profile is only helpful in children who have a neurosecretory defect in which the pulses and the peaks are obtended. There were papers when I was, when I joined DM, there were a lot of interest in doing urinary growth hormones. And I think it died down by the time we finished DM and started our endocrinology career. So that is an absolute no-no of doing a urinary 24-hour urinary growth hormone estimation. The only thing clear in doing a growth hormone testing for growth hormone deficiency, especially in our country, is that before we test for growth hormone deficiency, we have to make sure that the child is not hypothyroid, the child has normal thyroid functions, as well as we have ruled out all other chronic systemic illnesses, commonest of which being celiac, anemia, all those. Because even in our practice, Shaila will bear with me that even today, we still see children coming for short stature, but turning out to have celiac disease, chronic giardiasis, chronic malnutrition because of malabsorption, and primary hypothyroidism. In the absence of a newborn screening, we still miss out a lot of children with primary hypothyroidism. So all those things have to be ruled out before we take up a growth hormone stimulation or a growth hormone test. So if we can't do a random measurement, we can't do a 24-hour growth hormone profile, what do? We do a stimulation test, and here comes the role of the control of growth hormone secretion. Just a brief overview that growth hormone is secreted from the pituitary under the control of a balance between growth hormone releasing hormone and the inhibitor, the somatostatin. There are various other stimulating and inhibitory factors. The important stimulating factors are a physical exercise, sleep. These are the physiological factors. The amino acid, especially arginine, then hypoglycemia, and gonadal steroids are required for an adequate secretion of growth hormone, especially during the peripubertal period. What are the inhibitors? Inhibitors are free fatty acids secreted from the adipose tissue, IGF-1, which has a negative control on growth hormone, and hyperglycemia. So this forms the basis of all the stimulation tests. So what should be an ideal stimulation test? An ideal stimulation test would be something which has the ability to accurately and reliably differentiate between a child who's growth hormone deficient from a growth hormone sufficient child. It should have high reproducibility. The agent used for stimulation should be safe with minimal side effects. The test should be simple to perform and it should be of a very short duration. So these are the various tests. So do all these stimulation tests hold true on what I said about the ideal stimulation test? Up till now, insulin tolerance test has been the gold standard, but all of us know that it has its inherent risk of hypoglycemia, cannot be done in very small babies or newborns, as well as in elderly, and especially in patients who have risk of epilepsy and convulsions. Physiological is exercise and sleep. There are no standardized methods to do it. So they are not in vogue. Earlier exercise was used, but now it is not used. The pharmacological agents used are glucagon, clonidine, arginine, along with GHRH, and L-dopa propranolol. Of all these, glucagon and GHRH, arginine are the most commonly used in the days when we cannot use an insulin tolerance test. But there still remain issues and confusions with the stimulation test available because there are certain factors which determine the peak GH concentration. What we need to see is during these tests, does the GH rise beyond a certain level, which marks the cutoff? So all the controversies come at this point of time of stimulation tests because of the problems with the assay, the standardization or the calibration of the assays. These are all the pre-analytical or the analytical factors. Then come the patient factors, in which in the presence of renal disease and liver diseases, the patient will have growth hormone resistance. And in renal disease, the clearance will be low. So the falsely high GH would be measured in spite of the patient having growth hormone deficiency. And other patient factors are nutritional status, BMI, which I would discuss subsequently. So what are the issues with the assays available for us for growth hormone? They are not reproducible. The same test performed in the same patient over 2 or 3 times, you may not get the same consistent results. Different tests done in different patients or the same patient will not give you the same results. So they are absolutely not reproducible. So the first point of ideal stimulation test goes off. The assay inherently has lots of issues, which creates confusion. There is a study was done in UK where they did in 40 labs, the same sample was measured and the variation was up to the tune of 25%. So the sample actually had a value of 7 microgram per liter, but it would measure in different labs from 5 to 10. So the standard definition of growth hormone deficiency, which was accepted, was 7 or 10. So in certain labs, the patient would be diagnosed to have growth hormone deficiency, and in others, the patient would be sufficient. We know growth hormone is a heterogeneous molecule with 22, 20, and 17 kilodalton weight. And because of the various protein modifications, the binding of the antibody would be different, and this would affect the measurement. The growth hormone circulates with the bound to growth hormone binding protein. So the antibody which is used in the assay, if it binds to the epitope where the growth hormone is bound to the GHBP, it will not measure. So it will measure a falsely low growth hormone value. Earlier assays had a polyclonal antibody in the immunoassay. So the values found in the previous versions of the assays were higher. So the cutoffs were 7 microgram liter or 10 microgram per liter. But now the immunoassays use a monoclonal antibody. Again, it binds to a specific epitope. If that epitope is changed because of various factors circulating, or because of the GHBP, or because of silation or proteoglycans, then again, you would have a falsely low growth hormone measured. The reference standards used for calibration also have changed over time. Earlier, it was a pituitary-derived standard which was used, which had different potency. So the assays would be calibrated with the growth hormone standards of varying potency. So one assay cannot be compared with the other assay. Now it is recommended to use a recombinant GH standard provided, and all assays should be calibrated with that. So we are trying to overcome issues or confusions with the various assay technologies. The earlier assays used to report the growth hormone level because of units per liter, in spite of the actually measuring the protein, which should actually be reported in a mass which is micrograms per liter. And the cutoffs over a period of time have changed. Earlier, the cutoffs used to be 10 microgram per liter, but as the levels of growth hormone which are measured by the newer assays has gone down, the values have come down even up to 5 micrograms per liter. So again, still there are these issues still remain in spite of the advancement in technology. So this is just to give you an example of a study published in JCM, where they tried to compare 7 different assays along with the mass spectrometry, where the actual value of the sample was 7 microgram per liter, but you could see that the assays measured from 4.3 up to 7.8. So such a wide variation in the growth hormone which was measured. So what should we do? I think the idea is to be comfortable with one assay and use the same assay with which you are comfortable, with which you know the details. And if you can have your own normal standards, it would work out better. But it is easier said than done. It's very difficult to have your own normative data or have this stimulation value for normal children in your own lab. Then comes as I said, that there are patient factors which affect growth hormone secretion, the most important of which is gonadal steroids. We see that at the time of puberty, that gonadal steroids stimulate growth hormone secretion. And in delayed puberty or in children who are pre-pubertal, when they are retested at the time of normal puberty, they have normal growth hormone values. So that is why the concept of priming came up. And priming decreases the false positivity rate from 39% to 5%. But it has been shown that there is no difference between patients who were not primed but not treated. So there was a group of children who were not primed. They turned out to be growth hormone deficient, but they were not treated. So the final height with these children achieved was not compromised. That means that if they were not primed, growth hormone deficient, it did not make any difference if they were not treated. So even in the pediatric endocrinology circle, there is a diagrammatically opposite view of priming and not priming. And probably half of the group of pediatric endocrinologists, they prime. Then again, the agents used for priming and the age of priming varies. Some people prime all boys 11 years and above, or they take the bone age. The practice which we have in our clinic is all girls 8 years and above and all boys 9 years and above we prime. Girls we prime with ethinyl estradiol 10 to 20 micrograms for 3 days prior to the test, and boys 100 milligram of testosterone enanthed given 3 to 7 days prior to the test. Again, the agents and the days of priming also vary. Boys can even be primed with with ethinyl estradiol because estradiol is the primary agent which stimulates growth hormone. And as I said, that fat and the free fatty acids liberated from the adipose tissue has an inhibitory effect. And we know that obese adults, the spontaneous and the stimulated GH is low. Similar is the situation in obese children, that the spontaneous and stimulated GH peaks are low in obese children, and they increase the false positive diagnosis of growth hormone deficiency. So in adults, there are clear-cut BMI-dependent cutoffs for the agents used, but that is not so in children. And should we be doing it is still not clear. So to overcome this, what is the alternative? Can we have the biomarkers, which are the actual product which functions, which carries out the function of the growth hormone, which is the IGF-1, which is produced from the liver, and it is also produced in the growth plate, which has a paracrine and an endocrine effect. So should we use an IGF-1 level, which will help us get over all these problems and controversies of the growth hormone stimulation test? Let's see what IGF-1 tells us. It's a stable and circulates bound to IGF-BPs. So measuring this is easier, but you need an extraction step needed for the free IGF-1 estimation. And most of the automated platforms which we are commonly using now for all hormone measurements don't have an IGF-1 assay. And the problem lies that under 3 years, there is a considerable overlap between the IGF-1 values found in normal children and a growth hormone deficient child. IGF-1 has a role to tell you that the value less than 2 SD is highly predictive of a GHD, and a value, if it is 0 and above standard deviation score for age and sex matched normative data, then GHD is unlikely. IGF-1 is reduced in children who have malnutrition, renal failure, chronic diseases, and diabetes because there is a condition of growth hormone resistance. So again, in these children, you cannot use IGF-1. The IGF-BP3, which is an important binding protein, is GH dependent and it is not affected by nutrition. So there was in vogue that IGF-BP3 could be used. And again, it is a stable compound. So it could be used to assess the growth, the level of growth hormone in the body. But then again, it has a very poor sensitivity, just 50%. So we are none wiser using the biomarkers of IGF-1 and IGF-BP3. So what can be done? Can we use auxological criteria, as Shella pointed out, that what should we do? Should we use auxological criteria for diagnosing short stature or a growth hormone deficient child? It was one of the parameters used in Australia. Actually, they start growth hormone therapy. They don't have to do growth hormone testing if the child has auxological criteria fulfilling growth hormone, fulfilling that the child is short. All those criteria of -3 SD, poor growth velocity, short for mid-parental height. They never required to document growth hormone deficiency prior to starting growth hormone therapy. But then there are so many other conditions which will have the similar auxological criteria, auxology or anthropometric parameters as a growth hormone deficient child. A child born SGA, a child of idiopathic short stature, all of them will have the similar features. So should you not do a growth hormone growth hormone test? Because I would still say that we should do a growth hormone test because we are embarking on an expensive therapy. I, for once, would like to be convinced that, okay, this child has an anthropometry suggestive of short stature, has growth hormone deficiency. It convinces me, or at least makes me sleep better when I start therapy in such a child. Then, since the assays and the stimulation tests have so much of problems, it is always recommended to do 2 tests in patients who have a low pre-test probability of having a growth hormone deficiency. In patients who have MPHD or who have a setting which says that they are likely to have a growth hormone deficiency, even a single test suffices. In rest, all other patients, 2 tests are required. So after having seen that growth hormone stimulation tests are not good, biomarkers are not good, anthropometry has its inherent problems, are there some additional tests which we could add on to help us make a judgment about growth hormone deficiency? And yes, neuroimaging does help us if we have a proper pituitary protocol. There are 2 or 3 types of neuroimaging abnormalities which we could find in patients who have growth hormone deficiency. What we have to see is the anterior pituitary, the stalk, and the posterior pituitary. These 3 things have to be looked at carefully, and the various MRI findings in hypopituitarism which you could get is an ectopic posterior pituitary. You could see that it's lying high up there in the median eminence. All these 4 are ectopic posterior pituitary, or sometimes you could have a double posterior pituitary. Here you have a hypoplastic and an interrupted pituitary stalk. Again, here the stalk is interrupted with a double pituitary. So all of these findings, if they are present, it helps us to make a judgment that this child is likely to have other pituitary hormone deficiencies, or other pituitary hormone deficiencies are likely to evolve over a period of time. And if the GH values come as unstimulated or undetectable with a low IGF-1, it helps us to make a diagnosis and start the treatment as necessary. This is just to give you an overview that along with neuroimaging, now with the availability of NGS and whole exome sequencing, it helps us to know that there are lots of genetic mutations which confirm the diagnosis of isolated growth hormone deficiency or multiple pituitary hormone deficiencies, depending upon the phenotype as well as the neuroimaging findings. If you have ocular abnormalities like nystagmus or septoptic dysplasia, HESX1 mutation is the most common. So what happens when these children transition to the adults? Many of the isolated growth hormone deficient children have a normal stimulation test when retested. There are lots of reasons why this happens. First and foremost is because of the assay problems and the stimulation tests inherently which have problems. And the other reasons are that certain diseases like brain trauma or the cranial irradiation, the growth hormone deficiency may be evolving. Who are the children who need to be retested as adults? Children who have MPHD, MRI showing gross pituitary abnormality don't have to be retested. They can be continued on growth hormone therapy. Children who have isolated growth hormone deficiency and a normal IGF don't have to be tested. Rest all children should be retested before you continue growth hormone therapy in adults. And in adults, the agents used are glucagon and morelin, which is an oral growth hormone secretagogue. And as I said, that BMI makes an effect, does have an effect on the stimulator of the peak growth hormone values. So in adults, you have clear-cut BMI dependent cutoff values for growth hormone deficiencies. In glucagon for obese, it is 1 microgram per liter. Morelin actually is not affected by BMI. So the value which is given is 3 microgram per liter. But now the recommendation is to use a standard 5 microgram per liter as a cutoff value for diagnosing adult growth hormone deficiency. So to conclude, I have tried to show you is that issues still remain with stimulation tests. We are nowhere near the optimal or a reliable or an ideal stimulation test. Oxological criteria, results of a stimulation test, along with neuroimaging and genetic testing, is like clarifies the situation in most of the cases. We really need to monitor the response to therapy. If the therapy is not adequate or as it should be, even in spite of the patient being compliant, and all other factors have been looked into, then we need to rethink and relook at the diagnosis. And at least the weight is still on to have all these controversies and confusions to be removed from diagnosing growth hormone deficiency. Thank you.
Thank you, Dr. Preeti. Do we have any questions? Okay, I'll start off. You discussed the pharmacological stimulants, but if we take in India, we use mostly clonidine stimulation.
Yes.
Because arginine availability is very bad, and glucagon also not very easily available. So what do you say about clonidine stim test?
That is the first test we also use in our clinic. That is the first test. When I was training earlier on, we used to use L-dopa propranolol also. We have used very often, but now we use clonidine as the first test, and we do manage to get glucagon. So if we need to do a second test, that is the second test which we do. But the first line test is always clonidine.
Yeah, but I still feel ITT is the gold standard. And
yes, I agree with you.
In PGI, we used to have kids lying down, and just because you're not monitoring properly, I think these incidents have happened. Otherwise, it's always safe, and it's always, you'll get a quicker or good response, and you can be 100% sure with the ITT. But
I agree with you, Shaila. We have also used it, but last 15 years we have cut down. But as you said, that when I think both of us were training, that was these tests which we used always.
Yes, correct. So we are all ancestors.
Yeah, I think we've grown old.
And also priming, I think we all do priming.
Yes.
It is better if we do priming because we'll get better results. And as you said, eucortisol, euthyroid, rule out all the systemic diseases, and then prime, and then do the clonidine or whatever available agents, and then get the conclusion.
Yeah. I think chronic diseases is the bottom line. And just to add on that, not just the celiac, we have picked up renal tubular acidosis with just hypokalemia. So electrolytes also is a mandatory now. VBG and an electrolyte. Just do it because it's such a simple test to do, and you are wiser doing all these before you even think of doing a growth hormone stimulation.
Yeah, I think I would suggest anybody who is looking after the pediatric short stature, first do the screening test, and never forget to do a bicarb, rule out RTA, VBG, and celiac if you really suspect with the symptoms, bone age, thyroid. But if you don't do these things and straight away go for a growth hormone stim test, I think it's completely wrong. So first rule out, because many children we are picking up RTAs who are coming with severe short stature, like -6, -7, they are coming and still SDS, but still they turn out to be something non-GHD, which has to be taken care, and not to give growth hormone for these kids. Okay, let me check if we have any.
Bhattacharya, Dr. Vaishali has a question in the chat box.
Okay. So would IGF-1 with IGF-BP3 assay combined with oxology replace GH stim test in future?
As I showed you that there is so much of overlap between the values of IGF-1, IGF-BP3, especially in the group under 4 years, under 5 years, and definitely under 3 years. We don't recommend even doing IGF-1 under 3 years of age. There's a significant overlap between GH deficient, sufficient and deficient children. So I don't think it can replace in those under 3 years. Maybe later on, but not under 3 years. So we will require something for those
below
children.
3 years, IGF-1 is not very helpful. IGF-BP3 is okay. But above 3 years, IGF-1 can be done along with IGF-BP3. And we do have a few Indian standards, so we can refer them and use them. Dr. Kadilkar's some IGF-1.
Yes, they have some data.
Yes, so we can use those normative data and compare them while treating or if for diagnosis. Okay, thank you. If I think we don't have any more questions and we are already running out of time, but we'll move on to the next very interesting, very common, very complicated topic about early or precocious puberty. For this, we have Dr. Kalpana Dash, who is currently working as Chief Consultant Diabetologist and Endocrinologist at Apollo Sugar and Endocrine Care Center of Excellence in Raipur. She is associated with all the Apollo hospitals of Bilaspur, Raipur, and she is also adjunct professor at Apollo Education and Research Foundation. So hopefully Kalpana will discuss about why we are having precocious puberty or early puberty now in last 2 years. And I think along with this COVID pandemic, we are having obesity pandemic in children and also precocious puberty pandemic in children. So over to you, Dr. Kalpana. You could introduce your the panelist.
Ma'am, if you can introduce the panelists.
Yeah. Okay. Thank you, Dr. Saila. And I must thank the organizers for giving me this opportunity to be a part of this symposium. So we'll have a panel discussion on early puberty versus the precocious puberty, the controversies. So we have with us panelists, 4 panelists, but one of our panelists will not be there. So we have with us Dr. Jayashree Gopal and Dr. Archana Juneja and Dr. Varsa Jagtap. So here we have Dr. Jayashree Gopal, who is the Director of Diabetes Endo India, Chennai, that is Institute of Diabetes, Endocrine, Metabolic and Lifestyle Health. She's a DNB in internal medicine and endocrinology and diabetes. She's also a senior consultant endocrinologist diabetologist and attached to Apollo Hospital, Chennai, associate dean for teaching and research of MB Diabetes Research Center, Rayapuram, Chennai, and recipient of Vocal Excellence Award from Rotary Club and award the Dr. Sam G.P. Moses Oration at the API Chennai Chapter Annual Conference. And second is Dr. Archana Juneja, who is from Mumbai, and she's a consultant endocrinologist in Kokilaben Dhirubhai Ambani Hospital, Mumbai. She's a PG guide for DNB endocrinology and especially interested in neuro and reproductive endocrinology, thyroid type 2, type 1 diabetes. She has many publications, around 10 in indexed national journals. She's a guest reviewer in British Journal of Neurosurgery, invited guest faculty at regional and national diabetes and endocrine conferences, API, anesthesia, ENT, and gyna CMS. And she also has honors and achievements, many of them. Next. So here is Dr. Varsa Jagtap, who is MD and DM in endocrinology. She is the assistant professor in endocrinology at BHRC Pune and consultant endocrinologist at DMH and Jagtap Clinic and Research Center, Pune. She has about 25 national and international publications. She is also an awardee of Dr. Palekar Prize, late Prabhakar Ramdas Sadale Prize. Is his gold medal in this, and Best Paper Award in ESI 2011, Clinical Radiological Correlation in Idiopathic GST, and Best Interesting Case Presentation at Amrita Certificate Course in Endocrinology held in AIMS Kochi in 2011. She also has Best Paper at ITSCON in 2011, Prevalence and Impact of Thyroid Disorders on Maternal Outcome in Asian Indian Pregnant Women, and Best Resident in GSMC and AIMS Mumbai 2012. So we have three panelists with us, and so we'll be discussing about the controversies in the early versus the precocious puberty. So as you know, precocious puberty is a complex endocrine problem occurring at an unusually early age, that is 8 years in girls and 9 years in boys. However, there are also certain variations we can have, and some papers have been shown the cutoff across India, that is in the North India, that is girls it is 8.1 years and for boys it is 9.2 years, and the process is basically triggered by the tumors or maybe certain injury to the brain, or maybe most of the causes could be idiopathic. And 50% of the cases may not progress or regress without treatment. Diagnosis and management remains a challenge in all of the setups, and because of the absence of standardized guidelines and GnRH analogs, they are the mainstay of the therapy. And in some situation we can use other drugs also like MPA. And it's a concern for the kids, family, and the physician, and there is an urgent need for clinical trials and registry system in our country so that we can establish the Indian cutoffs for the diagnosis, treatment, and follow-up for the precocious puberty children. So I have made 16 questions. So I'll put maybe 3 to 4 questions to each panelist. And we have with us about 30 minutes. We will try to have the answer in very quickly, and maybe later on we'll have a discussion on that. So should I start with the questions?
Please, ma'am, please go ahead.
Yeah. So one by one, I'll start the question. The first question will go to Dr. Jayashree Gopal. So looking at the scenario, so this precocious puberty, is it always a disease, and what are the apart from the conventional causes like the tumor and the brain injury and the idiopathic? So what are the exogenous causes of the precocious puberty and how common are they? This is the question for Dr. Jayashree Gopal.
Good evening, everybody. As we all know, precocious puberty is quite often idiopathic in girls and more commonly associated with a pathology in boys. The reasons for why girls the world over are getting having an earlier puberty are many. One is, of course, what Dr. Shaila was mentioning, the increasing prevalence of obesity in younger children. And apart from that, other postulated causes have been exposure to endocrine disrupting chemicals, and also maybe inappropriate media exposure has been postulated as a cause. So many reasons why it is believed that girls the world over are attaining, at least starting the pubertal signs. Whether or not they actually attain puberty, they're starting the pubertal signs at a relatively young age. But most often what we find in young girls is it's idiopathic, no particular cause is determined.
Yeah. Thank you so much. And the second question is for Dr. Archana. So what are the variants of the precocious puberty and should they be evaluated? And what is the management if the parents are really concerned about such situations?
Yeah, thank you, ma'am. I think this is a very common scenario which we encounter in our clinical practice. Many a times we have mothers walking in with their young girls, 6 and 7 years, with some pubic hair or some with axillary hair. So, we have actually, they had defined variants which are called variants of precocious puberty. So these are not really true precocious puberties, but and because they don't really follow the activation of the hypothalamic pituitary gonadal axis. But yes, we can see premature isolated thelarchy where there is only breast development, but without any pubic hair or axillary hair development. There's premature pubarchy, isolated pubarchy. Now, many a times pubarchy and adrenarchy are used interchangeably, but yes, that is a separate and a common entity. And thirdly, it is premature isolated menarche. So even menarche can occur by itself. Now, as we know, in girls, it's usually thelarchy, which is the first event to occur, followed by pubarchy and then menarche. So pubarchy and adrenarche are not really under the control of the HPG axis. It's the adrenals which usually dictate that process, and they are not governed by the HPG axis. So you can have girls who come with pubic hair or axillary hair. Generally, these girls, the way to differentiate is girls or even boys also, is there's no acceleration of the height. There's no increase in growth velocity. There's no increase in the bone age also. And usually they remain stable. Similarly, with isolated thelarchy, many a times girls come usually around 4 to 6 years. Now, 4 and 6-year-old girls coming with breast development is a little worrying for the parents. So we need to look at the other parameters. So the commonest things to look for is the height and the growth velocity. We should encourage our parents to plot their child's growth over a period of time. And if the growth velocity is not increased, and if they have not noticed any height spurt, it usually is going to be a very benign condition, which usually stays stable and may even regress in about a couple of years' time. So these are usually the variants of puberty. There's one more entity called as rapid tempo of puberty, where the sequence of events follow the natural course, but they happen very rapidly. Like if we talk about thelarchy to menarche being on an average between 2 to 2.5 years, the whole sequence of events happens within 1.5 years. So that is again not completely defined, but yes, some papers do mention this rapid tempo of puberty. So I hope that explains.
Yeah, very well explained. I would like to add something to Dr. Jayasree's answer. So exogenous causes, they're very common, and certain drugs also has been used, and herbal products and growth promoting agents and OCP used in mothers, estrogen cream among the mothers and grandmother, and youth promoting creams, and certain placental extracts also has been implemented in causing this precocious puberty, testosterone gels and use of lavender oil and tea tree oils, and some hormones containing hair products also have been implicated when mostly the African American parents, in 45% cases, they use these oils. So that also can cause precocious puberty. So next question is to me, because Dr. Pramila is not there. As you know, in developed countries, the age of menarche is declining at a rate of 2 to 3 months per decade. And some countries have proposed 7 years for the white girls and 8 years in the black girls respectively to define the onset of the precocious puberty. So should there be a consensus in revising the onset age to define the precocious puberty? How different it should be for the Indians? So definitely looking at the nutritional status and having a obesity is very common among the children, and it has been also seen because of the infection control also the puberty also has been improved. I mean to say it has been detected in an earlier age, and so looking at them, there is one study from the North India among the boys and girls from the schools. So it has been shown that 1306 school school boys from the school in the Delhi, aged 6 to 17 years from 7 schools. The median onset of puberty was 10.4 years, and the pubic hair appearance was 13.6 years, and no significant difference was found in the age of the attainment of the gonadarchy with normal or raised BMI, and precocity among these boys were observed in 9.2 years. And a similar study was also from North India among the school girls that have shown the median age of thelarchy at 10.8 years and precocity at 8.16 years. Puberty was observed at 11 years, and menarche was observed in 12.4 years. And overweight girls, they had 6 months earlier onset of thelarchy and the menarche. So I think this would be sufficient for this. And the fourth question goes to Barsa, Dr. Barsa. So is it just a hormone which is really implicated for this disease, that is precocious puberty, or is it fat, or is it something in water, or is it something to do with any endocrine disruptors? Please explain them, and something in regard to the pathophysiology, if possible.
Yes, thank you, ma'am, for the question. If we talk about pathophysiology, I think first we all know about the physiology, that it is the pulsatile GnRH secretion from the hypothalamus which actually triggers the puberty. There are a potentiator like cispeptin or neurokinin, and there are going to be inhibitors to it like say MRKN and GABAergic neurons. So suppose if you have a gain of function mutation in one of the potentiators, so maybe a gain of function in cispeptin or a loss of function in one of the inhibitors, say maybe a loss of function of MRKN3, these are commonly described genetic mutations in precocious puberty children. And as has been already discussed, idiopathic is the most common cause. And if we were to do more and more genetic studies, I think the number of patients who have the genetic abnormalities would increase. So in females, we know that around so depending upon the age, 20% of the females could have organic abnormality or a CNS lesion, up to 20%. Sometimes the figure is as low as 3% only. And for males, the figure quoted is high. So if I were to talk about the endocrine disrupting chemicals, so as madam, you have already enumerated many of the endocrine disrupting chemicals, and I would just here like to add that so there were papers who have actually studied the plasma levels of these endocrine disrupting chemicals. So in one arm of the study, there were patients who were having true precocious puberty, and on the other arm, there were children with normal puberty. And they tried to see whether there was any difference in the levels of phthalates and BPA and the other endocrine disrupting chemicals. And so there are two main studies. One study showed that, yes, there were higher levels in particularly some metabolites of phthalates, but in the other study, both the levels were the same in both the group. So I think the jury is still out. We really don't know the answer, whether endocrine disrupting chemicals actually disrupt the puberty to a clinically significant level, and maybe larger and more number of studies will help us to answer this question. Thank you.
Yeah. Thank you so much. The next question.
Can I make a comment?
Please.
I came across something about adoption. So, is that a predisposition? Because there was a very controversial field saying that, especially children who are adopted from foreign countries, because we don't know, one is whether we don't know their exact date of birth, but whether, the psychosocial stress, a change, improvement in nutrition, all those things also can contribute to, overweight, obesity, and early puberty.
Even it has been said the better quality of life also. That has also changed the age of the puberty. Yeah, that is what I had also seen this one. Yeah. So next question to Dr. Jayashree. What are the challenges with diagnosis? This is very, very important. So how do we diagnose, and in Indian scenario, how we can cope up with this diagnosis?
So I think, thank you, Dr. Kalpana. I think the challenge really comes in girls who present about the age of 8 or 9 years. The challenge is to see whether it's truly precocious puberty, which is accelerating rapidly, or whether it is a slightly early start to the puberty with a slow tempo, so that the progression is not very fast. So the things that we are concerned about, obviously the number one concern is there truly precocious puberty? And for that we measure, I would measure LH and FSH and the estradiol levels, always assess the thyroid function. If there is any evidence of hyperpigmentation, I would also think about checking the androgens. The second is the child manifesting any evidence of a space occupying lesion in the pituitary gland? So like I said, that depends upon obviously the other general physical, the symptoms, a child who is, lethargic or headaches or vision problems, then we would consider doing more detailed neuroimaging to make sure that there is no problem. A third important component is obviously the bone age. So that's the other thing that we do, because that helps us decide whether truly it is precocious puberty, which is accelerating, causing an advanced bone age. So this is sort of a rough guide. There may be other tests which don't come to mind right now, but this is sort of a rough category of tests that I do. Based on this, I make the assessment about whether the child needs to have therapy immediately, or is it something that we can keep under observation. So if I think it comes under the second category, which is a slightly early start to the puberty, either because of obesity or whatever be the reason, I'd like to keep the child under observation for 6 months to 1 year usually, and I monitor the tempo of progression. I tell the mother also, see how much the height is going up by. If you feel that within about 3 months, the height is increased by more than 3 centimeters, please bring the child back. Or the changes, the breast development and all that is progressing rapidly, bring the child back. So usually we just monitor the tempo of progression of puberty to help us decide. Sometimes the diagnosis is clear cut. We know it's definitely precocious, advanced bone age, idiopathic, and also the benefit of treatment is more the younger the child. So in a 6-year-old or a 7-year-old child, definitely there is no doubt. Anyone above the age of 8, it becomes a bit more of a tricky and a nuanced decision at that point in time.
Yeah. Thank you. So, well explained. And the next question is to Dr. Archana. Can you please elaborate on the clinical diagnosis, just because we are running short of the time? Clinical diagnosis, laboratory diagnosis, and the best possible dynamic test that is available in our country.
Okay, that's a lot of things to concise in 2 minutes, ma'am, but I'll try to.
you can increase because
this area is ridden with controversy. Yes.
Yeah.
So as Dr. Jayashree said very rightly, I think it's a clinical judgment, clinical acumen, which is most important. And here oxology stands paramount, I guess, plotting the height and the height velocity, the growth velocity of the child is important. And of course, keeping the target height and the in mind. Bone age is one of the most important tests. So if I had to categorize, the clinical diagnosis is going to be by examination. Examination will include the Tanner staging, both in girls and boys, because we need to decide, what is the height spurt happening, when is it expected to happen, and how much height potential is still left as such. The second is the general examination with respect to, the skin and the nervous system and the respiratory and the, systemic examination and all. The third is oxology, as we already talked about, and then going on to the labs. Now, labs, I think, a basic biochemistry screen would be done for everybody, but the bone age is the most important test. You can read by a Glitch and Pyle or Tanner Whitehouse too. So the advancement of bone age is a significant parameter. So if the bone age is not advanced beyond 2 standard deviations about the age, then I think we can wait. And either ways, any child with any degree of puberty, be it isolated puberty, isolated premature adrenarche or pubarche or thalarche, or a true precocious puberty, if we are in a little bit of a doubtful situation, there's no harm in waiting for 6 months to a year to plot and see the growth velocity. So the labs, bone age is important. And then going to the biochemistry, I think we need a baseline, though we do an FSH, but the LH is the most important parameter here. LH, testosterone in boys and estradiol in girls. Thyroid would be basically done, I guess, presume, so I'm not going to be talking about it. So LH level, we could do a baseline or we could do a stimulated level. Now, there are again controversies regarding the cutoffs. And as Dr. Preeti had already said, as time passes by, the criteria becomes stricter and stricter. I think 20 years back, an LH cutoff of less than 1 was supposed to be okay for, indicating suppression, immaturity of the axis. But today we're using an LH cutoff of 0.3, or some places even use 0.5. So if an LH is less than 0.3, it indicates, it's inactivity of the HPG axis, so it's still not active. More than 0.3 is more specific. Estradiol levels, I guess, again, less than more than 10 is more for puberty, and testosterone more than 20 nanogram per ml is considered. Now, most of the times, I guess, we are able to, looking at the clinical, the oxology, the bone age, and the baseline LH, FSH para, and the estradiol parameters, we are able to get to a a good diagnosis as to whether we need to treat this child or to wait and watch. But yes, in such conditions where when it's still not clear, we could go ahead and do the gonadotropin GnRH stimulation test. So they usually done with leuprolide, I think, which is commonly available in our country. It's not the depot preparation. We would use the short-acting one, 20 microgram per kg injected subcute, and then you would measure the levels, the LH levels after every 30 minutes for about 2 hours, and also the estradiol or the testosterone levels after about 4 hours and 24 hours. So again, here they say criteria differ depending upon the methodology used and the centers. So most centers follow criteria of LH more than 4 as indicating a precocity. But I mean, I would take all your opinions as to what I have honestly not come across. Me, I've not used this LHRH stimulation test, so GnRH stimulation test. So I will ask for your opinions, because then of course going forward, depending on this, we're talking all about central precocious puberty. Suppose we had somebody with a peripheral precocious puberty, you'll have to do the appropriate investigations, like if you have somebody with a virilization in girls or in boys with premature adrenarche, a 17-hydroxyprogesterone in both sexes, testosterone levels, DHEAs for androgen secreting for adrenal tumors, then beta HCG or alpha fetoprotein. So that would all be case-based evaluation. But a basal LH and a testosterone or an estradiol, I guess, is quite good enough. But yes, I will take the opinion of the house.
Yeah.
What are your other
I would request after the discussion to Dr. Saila and Dr. Preeti, so that they can guide us very well regarding this. So next question goes to Dr. Barsa. Is MRI brain indicated in all cases of the precocious puberty? If it is, so when? And is it different for girls and for the boys?
Yes, ma'am. So all boys with GDPP, that is gonadotropin dependent precocious puberty, should undergo MRI, because the chances of them having a CNS pathology are much more. When it comes to girls, girls less than 6 years in age, it is suggested to undergo an MRI, because the yield of them having any CNS pathology is much more. For girls who are between 6 to 8 years of age, we can decide depending upon case-to-case basis. Obviously, if a girl child is going to complain of, say, headache, or is having seizures, or is having vision abnormalities, we are going to go ahead and do an MRI at any age. But say, for example, if the girl is 7 years old, 8 years old, otherwise just having an early puberty, not having any other sinister symptoms and signs, we can discuss with the parents and give them the choice that, okay, the chances of the MRI coming abnormal are quite less, and we'll just wait and watch and decide on the treatment depending upon the rate of progression of the puberty. So this is how we can decide about the MRI.
Yeah. And thank you.
Sorry, ma'am. Sorry, ma'am, I
Yeah.
forgot to add about ultrasound. I think that just slipped my
Yeah.
mind. That's again a very important parameter
that's very
in
important.
girls and boys. Yeah, sorry.
Will you add now?
Oh, okay.
Will you add now?
Okay. Yeah. So sonography in girls, especially to look at the, both the uterine volumes and the uterine length, the ovarian volumes, the ovarian follicles, and most important, the copper cervix ratio. So there are again, these have changed across the time, across the decades, and across individual centers also. But generally, we look at, there are defined cutoffs. So uterus, I think volumes of more than 2 cc or the length more than 4 centimeters is considered a prepubertal. Ovarian volumes is a very sensitive parameter. So if you have ovarian volumes of more than 3 cc, it's considered to be pubertal. And again, the number of follicles. So multiple follicles indicates more of, a central precocious puberty, whereas a single follicle could be something like hypothyroidism, follicular cyst or so. Endometrial thickness is another parameter, and copper cervix ratio. So this is supposed to be a more sensitive parameter, which looks as the length of the ratio of the uterine length to the cervix length. And less than 1 is supposed to be prepubertal, and more than 3:1, the ratio is supposed to be definitely pubertal. But again, there are gray areas here also. So USG is an important parameter, which, sorry, I forgot to add.
It's okay. Thank you, Archana. So next question goes to Dr. Jayashree. What are the good predictors of height outcomes with use of the GnRH analog, and when should be started and how long should it be continued?
I mean, if the diagnostic criteria is controversial, I think this is one of the. There are some things we know. One is, like I mentioned earlier, the younger the child, and the better the outcome in terms of the height prediction. So one of the reasons we are using the GnRH analogs is for optimizing adult height. The more recent studies suggest that that is a little bit, but the younger the child and we start the GnRH analog therapy, the better the height outcome. So closer to the predicted adult height they will be. After the age of 8 years, it's unlikely that we're going to achieve much by giving GnRH analog therapy in terms of the final height outcome. Also, it's with respect to the bone age. Obviously, the more advanced the bone age, the less the outcome will be with respect to the height outcome with the GnRH analog, and also the what is the predicted adult height. So the age at which they come, I think, is the most important criteria to determine how effective our therapy is going to be.
Yeah, thank you so much, Dr. Jayashree. And next question goes to Dr. Archana. So we have with us two kinds of formulation of GnRH analog. One is 1 month depot and other one is 3 month depot. So which formulation is best among all depots? Is it 1 month or 3 month? And what are the advantages and disadvantages with these formulations?
Yeah, so ma'am, among the commercially available formulations, and I think I've used is more of the Leuprolide monthly as well as the 3 monthly depot. Studies have not shown any major differences between the two of them. They say both of them are equally efficacious and both in suppressing the puberty process. But the thing is, the 4 month, the 4 weekly preparation has more long-term studies, whereas the 3 monthly preparation is just very new in the market, so we don't have long-term studies, but short-term efficacy data is pretty good. In terms of side effects, adverse effect profiles, and also not major changes among the two. But among the that's what I came across. But with the other molecules, like in terms of the hysterelin or triptorelin, they were minor differences, and they looked at whether they found out that the patients who were prescribed a 3 monthly preparation, depot preparation, they needed to take the injections a little more frequently instead of 3 monthly. So maybe the pubertal suppression was better with the 4 weekly as compared to the 12 weekly with the other. But Leuprolide, I didn't actually come across any study mentioning a difference in the efficacy between the 4 weekly and the 3 monthly depot preparation.
Ma'am,
I'm very
sorry for interrupting this very interesting discussion, but we have certain timelines to.
Yeah, I know.
Sorry.
Thanks.
Okay, so finished. The other question is role of MPA. So when should we use this? So the question is for me because Dr. Pramila is not there. So when you start treating with the GnRH analog, so there is a LH surge and patient can have vaginal bleeding. So in that situation, you can co-inject this MPA so that the bleeding can be stopped. And second is when cost is a factor for concern for the patient, in that case also we can use MPA. A third, when age diagnosis is made at the age of 6 or more than that, in that case also height gain is a question. So in that case also you can start with MPA. So the other question goes to Barsa. In the peripheral precocious puberty, what is the role of aromatase inhibitor? Is it effective or not?
Yes, ma'am. So
Please be short. Yeah.
Yes, aromatase inhibitor, specifically letrozole, has got a role in patients who have GIPP in McCune-Albright syndrome. So the dose of letrozole which has been used is around 2.5 milligrams daily, and in studies it has been used even for a duration of up to 4 to 6 years, and it does reduce the chances of vaginal bleeding. It reduces the bone age advancement. when it comes to boys, the most common cause of precocious puberty is familial testotoxicosis, and in that, anastrozole has been used along with anti-androgens as one of the modalities of treatment.
Yeah, thank you. Dr. Archana, what are the long-term complications, 1, 2, 3, 4, like that?
So obesity, insulin resistance, PCOS, and metabolic syndrome. These
Dysglycemia,
have
dyslipidemia,
oh yeah, metabolic
psychological,
syndrome.
yeah.
Yes, yes, psychological. So,
Okay.
So these would be the important consequences.
Yeah. So how finished?
1, 2, 3, 4. I said.
Yeah. We're getting late.
Okay.
So anybody can say, how do you monitor? Monitoring its bone age, growth rate, height gain, and rate of pivotal development, estradiol level, and maybe a pivotal suppression score in the form of that is clinical, hormonal, and oxological parameters. And when do we stop treating these patients? What is the appropriate age?
11 years of age, I guess they say, for in girls and more than 12 in boys. That's I think Dr. Shaila Bhattacharya ma'am can and Dr. Preeti can answer.
And last question, maybe what is the effect on the bone density, bone mineral density?
So at the starting, ma'am, actually, when they are diagnosed as peripheral precocity, the bone mineral density of these children are actually higher.
Down, yeah.
And when they are treated with GnRH analogs, the increase in the bone density does slow down, but at the end of the treatment, it's almost same. So it's not that analogs are harmful on the bone mineral density in the long run.
Yeah.
They are.
Okay, thank you. The youngest mother in the world. Youngest mother.
Quiz.
Anybody? No. Youngest mother is a Peruvian from Peru, that is Linda Medina. So she delivered a child at the age of 5 on 23rd of September 1933. At the age of 5, she is the youngest. So I conclude, I would request Dr. Saila and Dr. Saila to give some tips, because they are the expert in precocious puberty. I just managed moderating this.
Yeah, here Shaila. Okay, Shaila and Shaila. So I think we need to be very clear, Shaila and Shaila. So that's one thing, because otherwise we both are getting confused.
Yeah, take home message or concluding remarks, please.
Yes. I thank you all very much, because all points were discussed. I thought of telling few points, but end of discussion, everything was discussed. Just take home summary or take home messages from this. I would say once a child comes with precocious or early puberty, tempo of puberty is very, very important. Always differentiate lipomastia with thelarchy. Never forget to do 17-OHP, because surprises are always there. And whenever you see a boy with precocious puberty, always think of pathological, and you have to really work to find the reason, and an MRI is a must. When it is girls, younger girls, MRI is a must, but again, borderline, like how Varsha said, usually they are idiopathic. Lot of our children, we are seeing that use of creams, like what Dr. Kalpana said, and we normally get all the creams from their house, and we see that there are some things which have got estrogens in those creams. So I think before we start investigating, we have to do that. And lifestyle management is definite first thing in all these children, and we also tell them to go on organic food. And last one is monthly versus 3 monthly. There are a lot of people who want to give monthly, and there are quite a few who wants to give 3 monthly. 3 monthly, Archana, has been very well accepted, and it's been there for many years. I usually prefer 3 monthly, because visits will become less. The child is not traumatized. Every month injection, and also the cost of injection monthly is much more when you compare the 3 monthly. There's a big controversy about 11.25 or 22.5 that we will not discuss here. which is 3 monthly. But some children do have pain after that deep IM. So that's the only thing. Otherwise, they're perfectly all right and no problem at all. I think we have covered everything. Thank you very much, all the ladies. Sheila, anything else? Preeti, any more tips? Take home anything? Otherwise, thank you very much.
Thanks, ma'am. Thanks a
Thank
million.
you.
I think I have the pleasant job of saying thank you to everybody.
Yes. Thank you.
Thank
Good
you
night.
so much.
And yeah, it was a wonderful program
It is a
session.
wonderful
Yesterday's,
program,
today's. Yes.
actually.
Yesterday
I
and today,
just
yes.
want to humbly say thank you to everybody who's taken so much of effort to make this program a success. So thank you from the bottom of my heart. A big thank you to everybody who's logged in. Thank you to Vaishali, Gagan, Belinda for being absolute pillars of support. Gagan, your camera, Vaishali, your camera, please. And Belinda had to go for a meeting. And I also want to, of course, thank the IT team. I've been chewing Mintu's brains in the background. So, and as I said, I would still like to repeat this, that a big thank you to ESI also, because there were some issues as far as the SOPs were concerned, but they really bent backwards to, be very, very happy to have this meeting under the ESI banner. So I still say that, so it's a big, big win-win situation for everybody concerned. So thank you very, very much. Thanks, ladies. Hats off to all of you. Thank you.
Thank you and happy Diwali to all of you.
Happy
Good
Diwali.
night.
Happy Diwali. Vacation.
Okay, good night. Bye.
Bye. Good night.
Bye. Bye, everybody. Bye.
Good night.